Arigato tasuku. Konnichiwa. Of course, endometriosis surgery for infertility is maybe better than one would think. Sorry, I'm getting some messages here on my screen. Thank you. I'm getting assistance from my opponents, which is lovely. I'll share my disclosures there, and you'll see that I work in both Auckland and Adelaide. I'm actually in Adelaide at the moment, I must also declare my potential conflicts of interest for this particular meeting, in that I too treat women with endometriosis with surgery, but also with medical treatments, assisted reproduction, as well as with Lipiodol. And here you see me doing all of the above there. And it's a reminder that that these things allow me to do very nice things with my family in New Zealand, and now thankfully the rest of the world. And I really would have loved to have been there with you in Kochi to share the meeting with you, perhaps on a future occasion if Wes and JES are able to tango well for the future. So the basis of my argument, and of course I won't be using any bias, is firstly the important role of laparoscopic surgery in diagnosing endometriosis, which I contend leads to precision fertility practice. That's important. An understanding of what actually causes infertility among women with endometriosis, as well as the important evidence base of laparoscopic surgical removal versus no intervention, and laparoscopic surgical removal of endometriosis versus other interventions. And I'll be focusing exclusively really on randomized trials. I'll be highlighting key guideline recommendations supporting surgery. And finally, most importantly, I'll come back to what we know to be true in our practice, and the crucial patient-centered viewpoint. So I think many of you will know that that we published a sequence of diagnostic Cochrane reviews looking at the non-invasive, so-called non-invasive tests for endometriosis, looking at blood biomarkers, urinary, endometrial imaging, as well as combinations of the above non-invasive tests. Really asking the question, can any of these replace surgery as a diagnostic test? Or can they triage surgery? And the bottom line is that while imaging is good for triaging surgery to take place in an appropriate setting with an appropriate surgeon, diagnostically, these all fall significantly short of laparoscopic visualization, which I think you're aware is not perfect itself. And this White systematic review shows that very clearly, that when we compare laparoscopy with histology, it's not perfect, but it's a lot better than the non-invasive testing. So we have a number of guidelines, of course, defining endometriosis, and an endometriosis is defined as the finding of endometrial-like tissue, obviously with fibrosis. It is a bit different, but it is tissue that's found outside of the uterus. And so it is hard to find that if one isn't doing surgery. And this is supported by the WES definition of endometriosis and also the ESCA definition of endometriosis, which you see here, the consensus definitions. Indeed, the only heavyweight guideline that is not promoting this finding as part of the definition or classification of endometriosis is the ESHRA guideline, which, of course, as you know, has, well, at least 8 good reasons why we should not be undertaking laparoscopy for diagnosis. And you've heard many of them eloquently already from Luke. I'm sure, like with the sermon in church with our Bibles, I'm sure you'll all have your ESHRA guideline with you. So if you turn to page 20, you will see that in the 3rd paragraph here, they're talking about diagnosing with imaging. And if you go back to the 1st paragraph here, where you would normally see the definition of endometriosis, somehow they've managed to completely omit the definition of endometriosis from the ESHRA guideline and to reproduce the 3rd paragraph. So I'm not quite sure what the definition of endometriosis is anymore based on the ESHRA guideline. The ESHRA guideline goes further and in fact does promote surgery in a number of different settings. And you've heard already from Luke about the endometriosis fertility index. I find this a very good tool at the end of a surgical operation for counseling patients. Indeed, I had an email only last evening from a patient who said to me, and I think this goes a long way to the issue of trying to generalize whether IVF or surgery is better. And the email from the patient read, "Professor Johnson, finally, I'm now pregnant. You told me 3 years ago at the end of my endometriosis surgery that I had a 70% chance of being pregnant within 3 years. And after 6 failed IVF cycles, we've managed to now conceive naturally." Do I rest my case? I'll go on. So how does endometriosis cause infertility? Now, I think biological plausibility of the surgical removal is important for us to have in our minds when we're thinking of how effective surgery is. So it's not just the anatomical distortion of fallopian tubes from ovaries, but it's the ovarian function itself and its higher control from the hypothalamus and pituitary. It's ovarian reserve, as we've already heard. It's ovulation, it's fertilization, it's the pre-implantation embryo whose quality is reduced among women with endometriosis, and it's implantation, as well as pregnancy. And we've heard a bit about the quickest path to pregnancy. Endometriosis is associated with pregnancy complications, as is infertility. So if we're adding another risk factor for pregnancy problems in IVF, that's not necessarily a good thing. And the quickest path to a pregnancy, if one ends up with a baby with an imprinting disorder, is not necessarily the most desirable path. Now, I know that also in Japan, you're interested in the peritoneal environment in relation to endometriosis. So other than restoration of tubo-ovarian anatomy, what is surgery actually doing? Well, excising it is exerting a positive impact on the intraperitoneal environment, and we have good evidence for this, probably enhancing egg quality and therefore embryo quality, and therefore enhancing fertilization rate. It is a little bit more speculative to suggest that surgery improves endometrial receptivity, or that it also removes the problems with pregnancy that are associated with endometriosis when it's been surgically removed. Let me now move to the evidence base. I've been generous to Luke here. I've presented the systematic review, which we published a few years ago, or a couple of years ago, when to do surgery and when not to do surgery for endometriosis. And one must acknowledge that that while the strength and the solidity of the evidence base has built over the years with regard to improving pain when one does endometriosis surgery, I don't think the solidity of the evidence base for improving fertility has in any way built. And you can see that it is at the borderline of statistical significance from our review, which was a little more punishing on surgery than was the Cochrane review. Now, you've already seen this network meta-analysis that we published a couple of years ago that Luke kindly showed. And I think you'll be aware that network meta-analysis is a way of comparing different interventions with one another that have not necessarily been directly compared in randomized trials in the one statistical model. So the nodes that you see here represent the interventions, the lines represent the comparisons, and the width of the line represents the strength of the evidence, or the numbers randomized. And you will see that laparoscopic surgery, or this allows us to prepare rankograms and then to construct a league table of the most effective interventions. And obviously, as we're from Australasia, down under, we present the top of the league at the bottom there. And you will see that surgical laparoscopy, as has already been highlighted, is statistically significant. But the confidence that we have in laparoscopic surgery is much more confidence than we have in any of these other interventions, which are in open loop comparisons, whereas surgery, because it's been compared with a number of things, we're much more confident about that evidence base. What I would say is that a significant omission here is IVF and IUI from this network meta-analysis. And the reason for that is that IVF specialists, I don't know whether smug is the right word for us in this regard, but we've never exposed IVF or IUI to randomized trials of the effectiveness of IVF or IUI in treating women with endometriosis. And we've only ever exposed those treatments to different ways of doing IVF or different ways of doing IUI. So I think that's important. And just to come back to the security of diagnosis, would you be wanting to expose some of these better interventions identified? I think in Japan, you know how good Loperidol is for treating endometriosis-related infertility, the Loperidol HSG, pentoxifylline, dydrogesterone, GnRH analogs. Would you be wanting to expose your patients to those interventions without a very secure surgical diagnosis of endometriosis and to use them empirically? I don't think so. I certainly wouldn't. So, yes, again, laparoscopic removal of endometriosis is supported by all of the key guidelines: the WES guideline, the Accept Australasian guideline, the ESHRE, the NICE guideline, and the WES, ESHRE, ESGA, ASRM, AEGL consensus guideline, as well as our very own New Zealand endometriosis pathway of care. They all support this. And interestingly, the ESHRE guideline, which is so tough on surgery, of the two options, it seems to be a take your pick as far as ESHRE is concerned, either IVF, medically assisted reproduction, or surgery. But what do we know from our experience? Some women will simply never have a child until or unless they have their endometriosis surgically removed. And I think that we all know this from our practice, and we know it, like my patient emailing me yesterday, from what our patients tell us. So I would contend that that surgery is an important part of treating endometriosis-associated infertility, because the effectiveness of laparoscopic surgery in removing endometriosis is supported by its rationale in removing some of the mechanisms of how endometriosis hinders fertility. It's supported by the randomized trial evidence base and by all internationally recognized guidelines. Importantly, the patient-centered viewpoint. But something that we shouldn't ignore, that the entire evidence base for fertility treatment in endometriosis hinges on a laparoscopic diagnosis. And are we just going to throw this baby out with the bathwater? Because without a surgical diagnosis, there is no evidence base. So I would contend that endometriosis surgery for infertility is surely better than we are now led to think. just a couple of meetings that that I'm involved in. Of course, I'm here in Adelaide, which I hope you all will be in September for the first face-to-face Aspire meeting for 4 years. And then finally, you've heard from Luke already. I hope that I will see all of you in Edinburgh in May at the 15th World Congress on endometriosis. So, arigato gozaimasu.
Thank you, Neil. You both talk about infertility surgery, endometriosis surgery for infertility from pro and con. And are there some question, comment, or opinion from audience? コウさんなんかありますか？どうぞどうぞ。プロフェッサーオスが。マイクロフォンあります？
Okay, Neil and Luke. So, Yutaka, I think both are true in some sense, but the point is, every endometriosis doesn't cause infertility. The point is, which endometriosis causes infertility? And the best study is, for example, the subject is those who have endometriosis and whose endometriosis is a real cause of infertility. And with those subjects, try controlled trial, IVF and surgery. So otherwise, we cannot find the true thing, because when you say endometriosis, maybe most of them might be unexplained infertility. Endometriosis might not be a cause of infertility. So if the endometriosis the woman has is the true cause of infertility, surgery might be an answer, or IVF might be an answer. So we have to wait further research. Thank you very much.
Okay. What do you say, Luke?
Look, I think that is a very valid point, very good point. What I'm not entirely sure about is whether we have any valid tests or markers to identify which women have endometriosis that causes infertility. I'm sure that the point is correct, that certain forms of endo may have let's just even argue that some types of endo may have a worse impact on infertility than others. I don't think it's necessarily linked to the severity of the disease, but I'm not aware of any markers or features that make it obvious what type of endo causes more infertility. Neil?
Yeah, look, Yutaka, I think that's an excellent point. And I'm actually going to back my truck up considerably here. And to develop your point a little bit further, you're absolutely right, Luke. I believe that there are no markers which will tell us that a patient will have infertility. They either end up having it or they don't. And if they have endometriosis, then we have to find some way of treating it. But I think our significant challenge is to wind the clock back to the younger women who may or may not be developing endometriosis, and to establish big databases of biomarkers which can predict the future. And therefore, I think that's our biggest challenge, to actually endeavor to prevent infertility in those who may be destined to develop endometriosis and to develop endometriosis-related infertility. So it's about awareness of endometriosis at a very young age and raising awareness, but it's also about developing evidence around predictive biomarkers and interventions which would be suitable for those individuals.
Okay, thank you. Thank you, Professor Osuga, making a big, challenging question. And I also think about when I heard both of your talk, I think individual approach is very important because patient very different age, their ovarian reserve and stage very different. So what do you think about this, Luke?
Yeah, I couldn't agree more. And I think I hinted to that in one of my very first slides. There are a number of factors that apply. I mean, even a simple thing like if you live in the United States of America where an IVF cycle costs a small fortune, it may well be that, you know, surgery is just the more cost-effective option. So again, I live in Australia where IVF is relatively cheap and affordable. And I think for many women, they see that as the preferred option, often also because they know from one IVF cycle they will have more than one embryo. So again, I come back to that point of there's maybe 1 or 2 or 3 babies from one egg retrieval, but that's not always the case. And certainly if there are often in couples multiple infertility factors, if the husband has male factor infertility, the surgery might deal with her endo, but the IVF would probably deal with both at the same time. So, but yes, it means you need to look, as always in good medicine, you need to look at the couple or the individual in front of you. And not only do you need to take all the factors into account, you need to ask her what she wants. I mean, I might be convinced that IVF is the best way for her, but if she says, look, I'm not interested in IVF, I don't want hormones in my body, I don't think that it's yet safe for babies to be born through IVF because of the epigenetic factors that Neil alluded to, then you need to respect it as a doctor. So it's all about providing information to your patient and coming to a joint decision.
Thank you.